welcome. We are in our final webinar of the Climate Change and Health Interest Group for SAEM and in partnership with the Wilderness Medicine Interest Group. We welcome all of you this evening to talk about global health. And so we are excited to have a group of panelists join us to share their expertise and experience in collaborating internationally on research and educational initiatives. We welcome you to join our interest groups, to post in the chat and pose questions as we move forward. This is a small group tonight, and so we welcome your input. Feel free to just stop any one of us. I will spend just a few minutes introducing our speakers, and then we will move forward. The first is Dr. Caitlin Moretti. She's an assistant professor of emergency medicine at Brown University in the Department of Emergency Medicine. Dr. Moretti has worked on the integration of refugees into the U.S. medical system. And more recently, she has focused on access to emergency care in post-conflict Colombia and environmental sustainability in healthcare in Rhode Island, with emphasis on advancing the health of vulnerable populations. Dr. Alison Hayward is also an assistant professor in the divisions of education and global health in the Department of Emergency Medicine at Brown University. Dr. Hayward served as co-founder, director, and now helps to oversee the executive board for the Uganda Village Project in rural Eastern Uganda. And she has for over 15 years with specific focus on community public health education and programming. She serves as the communications director for the Rhode Island ACEP Climate Change and Health Committee and the leader for the Rhode Island Hospital ED Green Team. And then we have Dr. Corey Bills. He's an assistant professor at the University of Colorado in the Department of Emergency Medicine and the Global Health Fellowship Director. Dr. Bills' current global health work focuses on methods of assessing quality in the development of acute care referral and pre-hospital settings in resource-limited settings, with particular focus in Liberia, Uganda, and India. So we welcome you all. It's wonderful to see your faces, and I will go ahead and turn it over to Dr. Moretti.
Great, thanks so much. Let me try to share my screen and see if this works. Are you guys seeing the just the slides or the presenter view? Did I get this correct?
We just see you.
You just see me?
Uh-huh.
Mm-hmm.
Oh, I probably need to hit, sorry, my technology skills are lacking. Hold on, let me try again. Okay, I missed a button. Okay, how about now? Better?
Excellent.
Yes.
Cool. Great. So thanks, Caitlin, for that introduction. So as a little bit more of a background, I just completed a global health fellowship at Brown, here at Brown, back in June of this last year, and then transitioned into faculty. And kind of during the year of fellowships, my work primarily focused in Colombia, and specifically with Venezuelan refugees and migrants on the northern border of Colombia and Norte de Santander. And initially, it was hard for me to kind of see the parallels between that global health research I was doing and my local climate change research and how those tied together. And kind of since diving in a little bit deeper, I'm here to tell you that they're very much connected. And the bit of time I have here today, I was hoping to kind of draw those parallels for you. So when we talk about kind of in general, the Venezuelan crisis, what we see in the media and kind of what we talk about and what we hear is some timeline that looks something along these lines, right? So we talk about the political upheaval, the political relations between countries, et cetera, and the impacts it has on the country. So you'll often hear about Chavez and his use of nationalizing the oil industry to decrease poverty and make social initiatives within the country. You then hear about Nicolas Maduro taking over in 2013, and oil prices start to fall nationally. And the government continues to spend money on these social programs, leading to inflation, food scarcity in the country as oil prices continue to fall, and the growing crisis that we've come to know. You hear about voter fraud when Maduro is reelected. And you hear about the US not recognizing the election, and you start to hear about the mass migrations out of the country. You hear about US oil sanctions. And then today, where we're in somewhere in the region of 5.4 million Venezuelans having left the country. What you don't hear about is climate change. But I'm here to tell you that it's there and it's part of this. So in the background of this Venezuelan crisis, between 2013 and 2016, Venezuela experienced one of the worst droughts it's ever experienced. It had 50 to 65% less rainfall than it had had in years previously. And this led to a rationing of water because of the drought, but also electricity because Venezuela relies heavily on hydropower. So within this time frame, in 2016, Maduro also implemented a mandatory 3-day weekend in order to combat electricity shortages. So this led to decreased agriculture output and augmented the general decline in the economy of Venezuela. In addition, we know that Venezuela has lost 4 of its 5 glaciers since the 1990s, and it's set to lose its last glacier in the next 10 years. In the same time period, we saw increasing heat throughout the country that led to agricultural loss, decreasing agricultural yields. There was also a migration of insects up into the higher latitudes that threatened agriculture and led to a bunch of crop destruction. So you can see kind of how this climate change underlying this political upheaval really was this threat multiplier that worsened the Venezuelan crisis, even though we never talk about it. There was also kind of implications of all these Venezuelans leaving to neighboring countries that increase kind of the effects of climate change. So for example, the illegal logging in Brazil in the rainforest that act as the lungs of the world greatly increased at the same time as the Venezuelan crisis, with thoughts that the Venezuelan migrants were turning to illegal logging as a source of income. And so you see these things go hand in hand. This is a picture of their last glacier that they're set to lose, the Humboldt Glacier. And if we think about kind of climate change as a threat multiplier throughout the world, we see that it really ties in with global health and kind of with where we work. So in 2017, 68.5 million people were forcibly displaced, which was more than any point in human history. 1/3 of these were thought to be displaced by sudden onset weather events, so flooding, forest fires, and droughts, which we typically will think of as climate events. And the remaining 2/3 of displacements were results of other humanitarian crises that the Venezuelan crisis would fall under. But as we've kind of just seen, it's really hard to distinguish these two things or put them into these clear buckets. So this is kind of a really interesting paper that looks at a model made in 2019 of if we continue a business as usual approach, where habitable areas will be kind of within our globe. So you can see our current situation, and the colors, the darker the color means that they're suitable for human habitation. And then as we move forward, you can see the changing color shows how certain areas are going to become less habitable. And this specifically kind of falls along the equator as things heat up. And this is exactly where we're seeing turmoil in the migrations now. So if we kind of look forward in time, in 2050, it's estimated that 1.2 billion people will be displaced worldwide. So the research that I do looks at specifically non-communicable diseases within this Venezuelan migrant population on the northern border of Colombia, and asks the questions, how can we calculate NCDs within this population? How can we treat NCDs within this population? And kind of what resources are needed to do those things. So while not directly linked to climate change, if we look forward, these are the kind of crises we're going to be facing more and more. And with that, I'll turn it over to the next speaker. There you go.
All right, Dr. Bills, would you like to go next?
Yes, hold on one second. Can you guys see this? Okay, cool. So I'm going to take a little bit of a step back from what Dr. Moretti talked about and provide a little bit of like the larger landscape of what the actual research around emergency care and climate change looks like in low and middle income countries. And just so you guys know, part of this was presented at the African Conference on Emergency Medicine as part of a one-day seminar on climate change back in November as well. So the aim really for everybody here and those listening later on is to provide a background on the current state of climate change emergency care in LMICs, see where we are in regards to current research with a little bit of a specific focus on emergency care research in Africa, and then talk a little bit about possible solutions to what is a fairly large research gap, or at least hopefully you guys feel like that's a research gap. So hopefully, as Kate kind of also said, or Dr. Moretti also kind of said, you know, sometimes it takes a little bit of a mental jump to kind of think about how the world of pandemics and climate change relates to health on a global scale. But the reality is, I think we've been thinking about this for a long time. So this is a paper from 1926 called Smallpox and Climate, published in the American Journal of Public Health, GPH, which basically made the connection between climate change and what at that time was the worst global pandemic of its time, which was smallpox. In the background is a picture of a sanatorium in Hawaii, in which the natural environment was thought to kind of clear smallpox. It was an area of isolation as well. And this article, kind of interesting, kind of found it in the context of reading a larger article about climate change and our more recent pandemic. But what they really said was, among the influences which we have been inclined to neglect is climate, or at least certain aspects of climate and season. So I think this kind of portends, I guess, this more recent article that was in the New England Journal by Dr. Salas and colleagues that looked at the climate crisis and COVID-19. And when the authors state that both of these crises disproportionately harm the health of vulnerable and economically disadvantaged people, including those affected by structural racism. And while it's certainly true and probably was written primarily for folks in the US, I think this extends quite readily on a global scale, and certainly to those living along the equator that are going to feel the effects of climate even more acutely than perhaps those of us in the US. So what do we do with that information, or what's kind of happened in the 100 years that we've written about this? Well, at least from an emergency medicine standpoint, we've been slowly increasing the amount of literature and research around emergency care. This from 2011 to 2015 really just tracks the number of emergency care articles in low and middle income countries. This is tracked through GMA. And on the left-hand side of the screen, it's stratified by EM care, disaster and health, and then emergency medicine development. And there's a similar logarithmic rise in the number of articles around climate change as well. The problem is that when you actually start to stratify those articles by type in terms of climate change, medicine or health more generally really makes up the lowest proportion of manuscripts on climate change itself. And then the bigger problem is that when you overlap those two sciences, the reality is that the amount of science within the published literature is actually pretty low. And so it's great to be on this call with other people that are really thinking about these things and to help maybe spur other people to start their own research. So in some ways, the issue isn't so much that we don't understand the potential risks or hazards related to climate change and human health. So this paper in The Lancet from 2006 laid out 8 different hazards that are well known within the literature perhaps not specific to low and middle income countries, but certainly for which there is a large amount of data supporting these as potential risks. Part of the problem is that while there might be adverse effects to some of these hazards, so if we just take temperature extremes, for example, there may be more daily deaths and disease events, but the reality in some areas of the world, depending on where you're working, there may be beneficial effects. So in more temperate climates or in areas where it's a lot colder, you may have less hypothermic deaths at more extremes as temperatures start to rise. So understanding that variability as it exists within specific locales, I think is important. But part of the problem, at least in low and middle income countries, is we don't have that level of granularity to be able to make recommendations one way or another about how these different hazards are going to affect patient populations in the areas that we work. This again also gives you a sense of what part of the problem is. So this article by Peter Bias in Global Health Action looks at climate change and population health in Africa and asks the direct question, where are the scientists? And part of that is that there aren't really good training programs for climate change and health within Africa or within other low and middle income countries as well. So not a scientific or systematic review. He looked at papers essentially that overlapped health, Africa, and climate change, came up with 31. That 31 papers does not necessarily include papers that had primary data attached to them. That being said, there are some nice papers out there that I think extend the conversation on what the issues are specific to Africa. So this paper actually looks at NCDs or NCD risk factors, neglected tropical disease risk factors as it relates to climate change in East Africa. And what they did was that they, I'm gonna let Alison back in. What they did was that they looked at the number of articles being submitted and then published over time. And they related that to kind of global changes from a policy standpoint. So for example, in 1988, the IPCC was established. And then more recently with a WHO global plan to combat NTDs in 2008 and a first WHO global report on the NTDs in 2010, we started to see a larger number of articles that looked at the risk factors from neglected tropical diseases and climate change. What they found, not too surprising, was that the most common causes of neglected tropical diseases studied were schistosomiasis and helminthiasis or human African trypanosomiasis, and that more often than not, factors related to those changes were precipitation and temperature. So a fairly kind of isolated group of hazards were looked at, and that less likely were droughts and floods, and larger kind of climactic changes or climactic events were looked at as well. And the kind of last kind of conclusion that they kind of drew from all of these papers was that there was a fairly large neglect of kind of local cultural context in terms of why these changes were taking place, and then adaptive strategies for how to deal with these issues over a longer time frame. Though not related to emergency care, more recently we've seen some research around emergency care capacity and adaptation to climate change. So Dr. Rublee, who's on this call as well, and myself and others looked at a review of how emergency units, which is EUs, are able to adapt to climate change on a local level. And of thousands of articles, there were really only 8 on the topic and 2 relevant or specific to Africa specifically, 1 in Tanzania and then 1 in Ethiopia. In general, the findings from that study were that there were variable emergency care provisions, a real lack of adaptive response, a lack of education and training for staff, and this is all compounded by a lack of funding that probably isn't that surprising. Specifically, the paper from Tanzania was a 25 hospital survey really to assess the disaster preparedness and response of capacity among Tanzanian referral hospitals, especially at the level of emergency care. And 92% of those hospitals reported experiencing some kind of disaster, and all were found to have inadequate numbers of healthcare providers to support an effective disaster response. And the top 2 of 3 disasters were all related to climate change specific to floods and then infectious disease outbreaks. So kind of beyond that, there isn't a lot of specific research related to emergency care provision, at least within the African context. And so really the kind of point of this is to draw attention to the fact that just promoting any kind of research within this context, I think, is important. There's been a notable increase in published material around global emergency care, and a similar increase around global climate change, but not really a relationship between the two has been made. Few articles address global emergency care and climate change specifically. Fewer still focus on measurements of change specific to emergency care, and even the non-emergency health related research relevant to the field it tends to focus on broad policy and without kind of specific localized data or local response. Few studies address ED specific capacity, and no studies provide data on implementation of African or locally derived tools aimed at the effects of climate change. So knowing that, what can we do? So I think it's pretty clear there's a need for more data on the relationships between systems development, climate change, and health outcomes in many contexts. We need to think about building human capacity to use data, to provide locally relevant support training and education initiatives, to create career paths for climate health research and advocacy. The first step, at least among my research, is to work with AFEM, which is the African Federation of Emergency Medicine. And we stood up the kind of first specific course for providers in Africa around that. That's available via Canvas to anyone that wants to access it. Secondarily, kind of proposed to use health and environmental data to support decision makers promoting climate relevant initiatives. And that primarily is through policy. And so part of AFEM's initiative is to stand up a declaration on climate change and health, something not dissimilar to what I think is running through SAEM and ASAP and other kind of bodies within emergency care. And so this is just the first line from the draft initiative. And if people want to learn more about that, I can give you access to the draft policy. Next is really to expand research specifically. And I think we can build on what already exists in a lot of places, which are local surveillance and environmental observations, and helping that to strengthen the burden of disease estimates, which have already started around emergency care. And then again, to think about supporting EUs or emergency units through the implementation and evaluation of locally appropriate programs to adapt to climate change, of which there really are no studies at this point. And then lastly is to use all of this to hopefully increase funding, because at this point, there is no, even outside of emergency care in low and middle income countries, isn't really earmarked funding from some of the larger funders around climate change. So Gates has not yet earmarked funds specifically for climate change and health, at least to my knowledge, and hopefully we can kind of build a science to support that work. So if you want to learn more about AFEM and its work and the work to help build a research agenda in low and middle income countries, or to support the research that you're thinking about doing, please let me know. And I look forward to the next talk.
All right, and I will go ahead and turn it over to Dr. Hayward as our third speaker. Welcome.
Thank you very much. Let's see, I think I need to be made a co-host again because I lost my connection. Sorry about that, I'm in a remote location. Thank you. Okay. Okay, can you see my slide? Excellent. All right. So I'm going to wrap up our talk by discussing something that is uh, more community-based in nature, related to the work that I do in Uganda, that was mentioned in my introduction, and I'll tell you more about what that involves. It's related to the nonprofit organization that I've been working with for almost 20 years now, called Uganda Village Project. And it's basically a public health organization that focuses on education and preventative health. And we work in small villages in a rural part of Uganda. And when I explain to you about the programs that we do and their impact and why they're important, I just want you to think about how these types of programs can really be applicable in so many settings. There are going to be increasing numbers of places where programs like these are needed and applicable. And so I think that, although this is about a specific organization doing specific work in a place, it also is really about something that is a worldwide issue that's being addressed by thousands and hundreds of thousands of other non-governmental organizations like Uganda Village Project. And so just think about that as you look this over. But Uganda Village Project specifically is an organization in Eastern Uganda that basically uses community health worker teams. And so in each community where we work, which we've selected by its need, basically by poverty, we serve those communities by helping them to develop a team of community health workers to carry out public health programs that focus on different areas that are critically important in places like rural Uganda, which include safe water, sanitation and hygiene, HIV testing and treatment, and also we help with malaria prevention. And another one of our programs is basically reproductive health and obstetric fistula. And so I'll tell you a little bit about each one of those programs and the relevance to climate change, because all of these things are relevant. So our mission is to facilitate community health and well-being in rural Uganda through improved access to healthcare, education, and prevention about community health. And so we've come a long way, because we started as just an organization of medical students that were international in nature, kind of a partnership between local Ugandan groups and international folks from the United States, including myself. And now we host an internship program, which is recruiting right now, if anyone is interested. We usually host 30 to 40 interns internationally every year. And we also have 6 full-time staff in Uganda. So what we hope to achieve is helping the communities in which we work to create and implement all their own health and development solutions. And I think you'll see the importance of that. So as I mentioned, these are our programs and these are the overarching goals of the programs. I'm going to mainly talk about the WASH, which is water, sanitation and hygiene, malaria, HIV, and then just mention a little bit about the reproductive health and obstetric fistula programs. So to start off, our water, sanitation, hygiene program is based around building wells, for the most part, in protected water sources. This is an example of a water source where we work. There are a lot that are less scenic than this and basically look like muddy puddles. And these are the locations where people will come with basic like plastic containers to fetch water and have to walk a long distance to carry this water back to their household for use in the garden or for use in the home for cooking and washing. And so you can see how this is a really serious problem for these remote communities, because a lot of time is spent each day devoted towards carrying water. Unfortunately, the water sources that are not protected are very susceptible towards contamination by fecal coliform bacteria from just open defecation, which is practiced in this area because of a lack of latrine coverage, and also because of kind of roaming farm animals in the area that are kind of grazing around these water sources. So water sources like these, which are just shallow, kind of puddle to small ponds, are going to be affected by climate change as they're increasing temperatures and droughts. And so it's estimated that the number of people living in water scarce areas is going to be increasing. Right now is somewhere between 2 and 3 billion, and it's supposed to reach more like 3 billion by 2050. And so this is certainly going to include many people in the low and middle income countries who need to access their water through sources like this one. In places like the region where I work, there is no running water, obviously, hence the need for fetching water from those sources. And so we help to construct improvised hand washing devices like this one, which uses all local materials. Basically, you can see it's called a tippy tap. This guy, whose name is Jamari, he's demonstrating how to use the tippy tap that he built, using it to wash his hands. So it's very simple to build, just using basically sticks and twine and what they call a jerry can, which is the plastic bottle. And when you tip the plastic bottle to use a little bit of water, then you can just, you have a bar of soap attached to the tippy tap. And this is a way in which we can facilitate hand washing and increased sanitation and hygiene and decreased diarrheal disease incidence, which is part of our goal. So another way that we address this is through, as I mentioned, protecting water sources. This is a well, so it's protected, it's got a cover on it, no one can get to the water inside, and it's drilled. We used to do hand dug wells actually with shovels, but now they're actually drilled boreholes. And so the water is less likely to be contaminated by surface E. coli and get into these jerry cans safely so that people can take it home, and somewhere along the water chain it is not getting contaminated by touching people's hands. So this is something that it may be increasingly in demand as temperatures rise, because people still will need to fetch water for irrigation and for home gardening and crops, and there's going to be increased transpiration with the increased surface temperatures, so they're going to have to spend more and more time fetching water, and if they don't have good water sources or water sources close enough to them, that's going to really impede abilities to do other economic, like income generating activities in favor of fetching water. So another way in which in these rural areas this problem is addressed is through the harvesting of rainwater. And so this is an example in Uganda of a rainwater tank. And these are used in school settings and other institutional settings at times to collect water for hand washing or for other use like cooking. And it's one way in which we can try to mitigate the decreased availability of groundwater that might occur based on climate change in a local area. So it's definitely something that is proliferating in the area where I work, that we're seeing more and more of these tanks for storage and for harvesting the rainwater. So another thing that I want to briefly address is malaria. You can see this is Florence. She's one of our village health workers. And so she's going from house to house and selling both WaterGuard, which is a chlorination product, to decontaminate kind of water at home. But she also sells subsidized nets to hang over people's beds. And so we pay part of the cost for those nets, and then people will purchase these nets and will help to ensure that they're properly hung and that the people who need them the most are using them. And so with climate change, there's going to be estimated to be increased numbers of people affected by mosquito-borne illnesses like malaria, dengue, Rift Valley fever. It's estimated that by 2100, 3% more of the Earth's population will be in malaria endemic areas because with the increasing temperatures globally, we'll be seeing malaria in more widespread, more temperate areas, and even at higher altitudes where previously they had been spared from malaria because of the altitude. So studies have been showing that when there are unusual rainfall patterns, as have been resulting from climate change, that malaria epidemics can follow. And also, I think it's obvious, but malaria is strongly related to poverty. And so if people are not, if people do not have the resources to address malaria prevention, such as by being able to afford nets or indoor residual spraying or other measures, then that makes them increasingly susceptible to malaria and other similar diseases. So it's estimated that for money that's being spent on cutting carbon, for every amount of money that you could save one life by trying to cut carbon emissions, that you could actually save 70,000 by just using policy measures to combat malaria. It seems like a lot, but I know that these interventions really only cost pennies and can save lives. So it's really one of the most cost-effective ways to save lives in settings that are in malaria endemic areas. So you can see a net hanging demonstration here that's being done by like a local community health group. And then also I wanted to just briefly bring up the HIV part of our programming. Obviously this picture was pre-pandemic, but these were people in our communities who are waiting for HIV testing, which is high demand in the region where we work. HIV is unfortunately common there, and maybe become increasingly common in parts of the world that are experiencing climate-induced migration, such as what Dr. Moretti pointed out. That type of migration will increase transmission rates of HIV, as well as the concern that people who are living with HIV and AIDS will be disproportionately affected because of their chronic illness by climate-induced natural disasters, such as flooding, which disrupt people's abilities to access their necessary medications and any other necessary medical care, of course, but specifically, critically, the medications. And so in addition to those obvious effects that climate can have on really anyone living with a chronic illness, including HIV, there's also, again, always the poverty aspect of it, which means that people may need to spend more time in trying to farm, and with decreasing yields, they're spending more time just trying to do their subsistence farming and have no time to travel to health centers and no income to spend on healthcare, which is supposed to be provided free in places like the area where we work. But unfortunately, as I'm sure you know, there are many costs associated that people do end up having to cover, and they can't even enter a health center at times unless they're able to pay for things like gloves and masks and basic medications to get through the door. So these are ways in which people like those in these communities are going to be very affected by climate change and any natural disasters that may be falling in these areas of the world. Also, we've got the sort of reproductive health and obstetric fistula part of our programs. Anything that would affect ability to get transported to these rural and remote areas is going to disrupt the ability of people to plan their families and to achieve their desired family size. And obviously that has a great impact on climate change just by the number of people that are existing in a given area. And that's the need that we're trying to serve. There's a great unmet need for family planning and for contraception in this area. And then for people who do choose to get pregnant, they may lack the funds because of poverty or the ability to transport themselves to a place that has advanced emergency obstetric care so that they do not have to face the risk of obstetric fistula from delayed presentation to a healthcare center where they can get a C-section if needed and do not have obstructed labor causing fistula. So these are basically some of the ways that I would consider climate change is affecting populations like the people that I've been working with and serving, but on a global scale. I think it's going to be very important for us to continue to consider these communities and what kinds of local solutions that we can create as things are changing. We're going to need to work together and adapt, and each community organization or NGO that's serving an area is going to have to think about the best ways to address these problems as they become increasingly prevalent. So thanks so much. Any questions? I'm always open to talking about our programs or anything related.
Wonderful. Thank you so much, everybody. I think that, just these three examples really highlight the connections, which are often quite complex, of climate change to our global environment. You talked about mitigation and reducing our greenhouse gas emissions, through international treaties like the Paris Agreement, but also adapting and building resilience locally, and how different these communities really are, even in resource-constrained settings. And so I think all of your work is a testament to what's being done globally to partner with our colleagues and help our patients ultimately as we move forward in a warming world. So with that being said, I open it now for any questions you may have. Hugo, you can stop the recording, please. Thank you.